Welcome to part 2 of Rapid Case Review, Management of Urothelial Bladder Cancer. This is medical oncologist Dr. Neil Love. I met with Professor Yohann Loriot from the GU Oncology Group from the Gustave Roussy in Villesuif, France, who responded to cases presented by Drs. Fern Anari from the Fox Chase Cancer Center in Philadelphia, Pennsylvania, Dr. Jacqueline Brown from Emory University School of Medicine in Atlanta, Georgia, Dr. Nazli Dizman from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Catherine Fahey from the University of North Carolina Lindbergh Comprehensive Cancer Center in Chapel Hill, North Carolina. We begin with Dr. Dizman, who is an 82-year-old man with a 40-pack-year smoking history, type 2 diabetes, who presented with gross hematuria and was found to have metastatic urothelial bladder cancer. Here's Dr. Dizman.
A lovely 82-year-old gentleman. He has a 40-pack-year smoking history, and he also has type 2 diabetes. He had presented with gross hematuria and was found to have muscle-invasive bladder cancer. His initial staging showed metastatic involvement in the retroperitoneal lymph nodes and pulmonary nodules. His first-line treatment was enfortumab vedotin plus pembrolizumab. His treatment course was notable for immune-related grade 2 transaminitis and inflammatory arthritis, both of which required intermittent treatment holds and corticosteroid treatment, but eventually we were able to resume treatment for him, so we didn't need to permanently discontinue treatment. Imaging studies first showed a decrease in the tumor burden, but more recently in the scans, we observed new borderline mediastinal lymphadenopathy. We biopsied that and it came back metastatic urothelial carcinoma. At this point, his immune-related adverse events are well controlled. He's off steroids and his performance status is 1. But unfortunately, from the EV, he developed grade 2 neuropathy. And we started him on SNRIs, and despite that, neuropathy continues, and it limits our ability to give platinum-based treatment. We did NGS. It doesn't show any actionable genomic alterations, and immunochemistry also shows no HER2-positive disease. For this case, I think I wanted to discuss a niche case, but it is not so rare given that our patient population is most of the time elderly. So we wanted to discuss subsequent treatment options in patients who are cisplatin eligible or for patients who are fit, but unfortunately have neuropathy and so won't be able to get cisplatin moving forward. For this case, I also wanted to discuss whether it could be an option to re-challenge patient with immunotherapy. So for this gentleman with 2 different immune-related adverse events that happened a few months apart, but at the moment controlled, my question would be to, 1, discuss the occurrences of these immune-related adverse events in patients receiving pembrolizumab in combination with enfortumab vedotin, plus its management and considerations about whether to re-challenge after patients had clinically significant immune-related adverse events.
So, of course, we know there's a spectrum of autoimmune toxicity with IOs. This patient had transaminitis grade 2 and also inflammatory arthritis. Any thoughts about if he was responding to treatment, re-challenge after these type of autoimmune toxicities?
I would generally not continue or re-challenge pembro alone after confirmed progression on EV pembro unless there is a long-term treatment break or equivocal progression or a local therapy strategy. Here, he had also 2 immune-related adverse events, so transaminitis and inflammatory arthritis. So since both are controlled and it seems he's off steroid, re-challenge could be considered if there has been a major benefit and no alternative at all. But I would not expect high efficacy after progression on pembro-containing therapy.
Any new opportunity, new agents, new drugs? At one point, I think sacituzumab, the TROP2 ADC, was being used in metastatic bladder cancer. Any new ADCs coming along that you're interested in? Any new immune-based therapies coming along that you're excited about?
Yeah, so here the case showed that we have the most difficult post-EV pembro scenario. So elderly, platinum limited by neuropathy, no actionable alteration, HER2 negative. So we have potential options for, first of all, gem carbo rather than cisplatin if neuropathy prevents cisplatin, taxane or gem monotherapy if frail. But clearly, clinical trial are preferred. So in the portfolio, I would say we have other ADC that target EGFR and HER3. So the Izabrain ADC. There is also some ADCs that target still TROP2 with different topo-1 inhibitors. So the SAC-TMT, for example, is something important to consider and currently investing in phase 2 trial. There is also the datopotamab that is investing in combination with chemotherapy. And we have to look for also the FGFR3 inhibitors. So here the patient has no FGFR3 mutation, but generally speaking, you can find FGFR3 mutation in 15% of the patients. So there is a drug approved, erdafitinib, and a lot of new, very specific FGFR inhibitors are currently investigating in metastatic setting. Sacituzumab govitecan is, so you know that we have a negative phase 3 trial, so it's very difficult now to provide SG to the patient. And so there is a lot of ADC coming, so and some are in phase 3 trials. So a lot of new drugs are coming for the patient, typically in this scenario.
All right. Well, speaking of FGFR, actually, this next case is a 70-year-old man of Dr. Brown, and I think this is the only time she's ever even used erdafitinib, but which I thought was kind of interesting. But in any event, here's the case.
70-year-old guy, history of diabetes, hemoglobin A1C always in that 7 to low 8s range. Prior non-muscle invasive disease, had intravesical treatments, and developed muscle invasive disease in 2022. He got neoadjuvant gem-cis for 4 cycles. He got a radical cystectomy, and he had a ton of disease at the time of surgery. He was T3BN2. And shockingly, his postoperative scans didn't show overt metastatic disease. So started him on adjuvant nivolumab, and while he was receiving adjuvant nivolumab, and this was sort of towards the end of his 1-year tenure, he got worsening lymphadenopathy, and we biopsied one of those RP nodes, and it was UC. He had a pathologic FGFR3 mutation on his next-gen sequencing, and so at this point, he started on EV. This was late 2023. His A1C was around 7.5. He had once he started very clear worsening of his blood sugars. He was showing up to clinic with blood sugars in the 300s. Luckily, he had a very responsive endocrinologist who helped me get insulin initiated in a week or so. And that helped a lot. And that was a big deal for him because he's like, I've had diabetes and I've never needed insulin and now I do. And it was a big lifestyle change. And he was understandably upset by it. I continued his EV through that. He had improvement on scans. And so soon after, he had progression of disease. He had some growth of disease in his anterior pelvis. You can see my arrow there. And so given his FGFR3 mutation, we started erdafitinib. This was my first and only patient I've used erdafitinib for. I was appropriately anxious. I was watching his phos. I knew that was a big deal with erda. It did go up. It went up to 7.5. I didn't stop the drug. I phoned a friend from residency who helped me start a phos binder, which I don't do all the time. And he had improvement. But at this point, I think the prior GI symptoms he was having, the weight loss, just the lack of appetite, were then compounded by stomatitis, diarrhea, more weight loss. We held the drug. I dose reduced again. So my question is, what are the rate limiting challenges for you when using it? How often is, the hyperphos, I think in the trials was like 70%, 80%. How much does that impact things? How do you manage it? Do you use phos binders? Did I screw up in that way? Is that the right thing to do? And then is it dose reductions when you're dealing with sort of those nail and GI side effects that it's so famous for? And then, At what point are there diminishing efficacy returns as we dose reduce to make it tolerable? And then the hyperglycemia with him, I made the decision of let's get you on insulin and we ride. Let's keep going because I thought UC was the most life-threatening thing to him at that moment. But how do you manage that? I think the package label for EV says, hemoglobin A1C greater than 8, don't use. In real life, I'm absolutely going to use while simultaneously getting that blood sugar down. Am I too much of a cowboy? What's the right way to do that? I guess it just depends on how sick the patient is at that time and how do you approach it. I practice in Georgia. A lot of my patients have diabetes.
So we actually did an entire CME program recently just on glucose intolerance in oncology, particularly breast cancer, have these PIK3 agents, et cetera. We see a lot of glucose intolerance. So before we get into the erdafitinib, what about hyperglycemia with enfortumab? Her question, if the patient has poorly controlled disease, diabetes, hemoglobin A1C above 8, do you treat the diabetes before you start enfortumab, or you just go ahead and do both together, which is what she did? And how often do you see this kind of issue with glucose with enfortumab?
So diabetes is not an absolute contraindication, but it requires aggressive monitoring, clearly. So the EV label note that hyperglycemia and DKA, including fatal events. So we have to remind that patients with baseline glycated hemoglobin more than 8% were excluded from the trial. So in real practice, if glycated hemoglobin is 7.5 and metastatic urothelial is life-threatening, I would treat, but I involve endocrinologists very, very early. I monitor glucose closely, and of course, I hold EV for significant uncontrolled hyperglycemia. And starting insulin was clearly appropriate here. So coming back to your question, so if we have time, we can refer the patient to the endocrinologist. If we have time, so meaning that the patient with, again, lymph node-only disease, slow-growing disease, so that's something you can consider. But if the patient is painful, has a lot of liver mets, for example, you can start, but you discuss with the nephrologist upfront. And for some patients, we start insulin very, very early. So here, the risk of developing serious hyperglycemia is associated with high BMI and history of diabetes, of course. So if you have these patients, high BMI and hyperglycemia, I would advise to call the diabetologist just before you start, just to ensure if you have to do some change in the treatment for diabetes.
Let's talk a little bit about erdafitinib. In a patient where you have a known FGFR alteration from the beginning, and you know that the patient has metastatic disease, generally, how are you thinking about where it's going to fit into the sequence of therapy?
So in 2026, for a metastatic FGFR3 mutated patient in first line, usually, of course, I give EV pembro first, if eligible. And then, so you have two options in second line, so three actually. So one, clinical trial. Number two, platinum-based chemotherapy. Number three, erdafitinib. So to me, there is evidence for giving erdafitinib in second line. It is highly relevant after progression to EV pembro because the data from chemotherapy are very, very limited. And we know that in this setting, probably erdafitinib can be associated with a response rate around 45%. So clearly interesting. And durability, the median PFS could be around 6-7 months. So in second line, if you know that the patient has FGFR3 mutation, I would use FGFR3 mutation inhibitor, so erdafitinib.
I don't know, the Venn diagram of HER2 and FGFR, do you ever see people who have both? And if so, which one comes first, TDXD or erdafitinib?
I think the level of evidence is higher with erdafitinib. We have a phase 2 trial in bladder cancer. So there was no patient previously treated EV pembro in the third trial because all the patients were treated with prior immunotherapy and chemotherapy. but probably we can extrapolate. And while with trastuzumab deruxtecan, we have a limited sample size, 50 patients, 30 patients. So it's active. It seems it's active, but I think the level of evidence is higher. So another point that you have to consider is the safety profile. So clearly, it's different between trastuzumab deruxtecan and erdafitinib. So another point is the way you give the drug. So erdafitinib is an oral drug, while trastuzumab deruxtecan is an IV drug. So if the patient again is fed up with the numbers of visits because the patient receives a lot of EV pembro infusion, sometimes the patient would prefer to receive an oral drug, so erdafitinib. So it's a case-by-case discussion with a fair discussion around the pros and the cons of each drug.
So we get so many questions about tolerability issues with erdafitinib, and she brought up a lot of them, beginning with phosphorus and phosphate binders, but also the patient had mucositis, diarrhea. Can you talk a little bit about how you prevent and manage these complications?
Yeah, so hyperphosphatemia is expected, and it's partly a pharmacodynamic marker. So it is associated with the inhibition of FGFR1. So it's expected. So I check phosphate at baseline and around day, I would say 14, 21. So I use dietary phosphate restrictions, phosphate binder when needed, and a lot of dose hold and dose reduction. So usually I start at 8 milligrams. So for some patients, I can escalate to 9 milligrams. But if there is any toxicity, so grade 1 moving to grade 2, I stop and reduce the dose and step up the dose to 6 milligrams. So something important, and proactively monitor eyes, because CSR is a key toxicity. It's usually reversible with dose interruption, but that's something you have to monitor. And clearly stomatitis, diarrhea, neck change, dry mouth, and fatigue often become the limiting toxicity more than phosphate alone, I would say. So maybe we have to remind everyone that the current label recommends starting erdafitinib at 8 milligrams daily, assessing phosphate at day 14, 21, and increasing to 9 milligrams only if phosphate is below 9 milligrams per deciliter, and there is no ocular disorder or grade 2 adverse events.
So I'm going to go on now to the last case, and I really appreciate when people present difficult cases for discussion where it's not clear what the best answer is, and kind of exposing their own thinking. And this is a pretty controversial case, I think. Well, first of all, interesting, 88-year-old man who actually started out with non-muscle invasive disease, getting BCG induction, and then showed up with metastatic disease to the lung with a biopsy-proven pulmonary metastases. And as you'll hear, ended up getting EV pembro, but had a complication and really started to get into a very difficult situation. Here's Dr. Anari.
At this point, he agreed to start treatment with enfortumab vedotin and pembrolizumab. He developed taste changes and decrease in appetite, and after cycle 1, lost 6 pounds. He continued on full dose treatment for cycle 1 and cycle 2, starting cycle 3 due to worsening fatigue, taste changes, and mouth sores. We reduced his enfortumab vedotin to 1 milligram per kilogram. His initial CT scan after 3 cycles showed a significant decrease in size of his metastatic disease. He had some new patchy consolidation in the left lower lung, which was concerning for possible aspiration. His oxygen saturations at this point were 100%. He then was found to have worsening fatigue, even on this reduced dose enfortumab vedotin. While he is an elderly gentleman, he was very active. He previously could walk 14 blocks without issue and now found he needed to rest after about 6 blocks, which was atypical. He continued on his dose-reduced enfortumab vedotin with pembrolizumab, and a couple of weeks after cycle 5, presented to our cancer center's urgent care because he had worsening dyspnea on exertion and new cough. He was found to have a CT chest that showed multifocal consolidative changes, for which the differential was pneumonia versus drug-induced pneumonitis. His clinical picture seemed more consistent with pneumonitis, so he was started on prednisone 1 milligram per kilogram with plan for taper, and pembrolizumab was held. He then returned to the office several weeks later. His exertional dyspnea had resolved. He had completed his steroid taper, and enfortumab vedotin was reintroduced single agent with a further dose reduction to 0.5 milligrams per kilogram. He completed one cycle with reduced dose EV alone. In November of 2024, his CT scan showed that his previously noted bladder cancer was unmeasurable. His pneumonitis had resolved, and he had resolution of his adrenal metastasis with stable mediastinal hilar lymphadenopathy that was likely consistent with treated disease. So given his excellent treatment response, we opted to go on treatment break. My question is, how do you distinguish if pneumonitis is from enfortumab vedotin versus pembrolizumab, and how do you proceed with reintroducing therapy? Another question I pose is, how often do you repeat CT scans for someone with an excellent response who's been off all of therapy? Another question that I have regarding this case is, how would you utilize the role of ctDNA in either the non-metastatic or, in this case, metastatic setting, especially with someone off all therapy whose CT scans show an excellent treatment response? And then what would you ultimately do with those results if the CT scans remain negative?
So a bunch of really interesting questions. First, taste change and decreased appetite. Have you seen that? Is that reported with EV Pembro?
Yes, it has been reported a couple of times. So that's something we can consider. We can see in some patients. It's not frequent, but that's something we can see. Yeah.
Any comments? Again, this gets into this issue of re-challenge. I guess thinking was that this was from the pembrolizumab. I don't know whether you. I think you can see pneumonitis from enfortumab, or you can correct me if I'm not right about that. But any thoughts? As I mentioned, it's such a difficult situation, but any thoughts about this case in terms of dealing with these complications, the pneumonitis?
Is it often impossible to definitively distinguish EV-related pneumonitis from pembro-related pneumonitis? So I manage based on severity, timing, imaging pattern, infection exclusion, of course, but both drug can be associated with pneumonitis. Also, pembro is the more classic culprit. The EV labeling include pneumonitis in case occur with EV alone or in combination with pembro, but clearly it's more related to pembrolizumab. So in this case, the patient developed dyspnea, cough, and multifocal consolidation after several cycles of EV pembro. So treating as drug pneumonitis with prednisone and audit pembro, to me, was very appropriate. And the question, very difficult, is the reintroduction strategy. So usually in my practice, if the pneumonitis was grade 2 and resolved fully, I will be cautious about pembrolizumab rechallenge, and especially in an 88-year-old with excellent response. So reintroducing EV alone at reduced dose is reasonable if ongoing treatment is needed. But if the patient has a near complete response or complete response, frailty, weight loss, I think observation is very reasonable to this in this situation.
What about her question in terms of ctDNA in the metastatic setting? We were talking about, obviously, in the localized setting, it's really revolutionized the approach to urothelial bladder cancer. We do see sometimes, I see people ordering for metastatic disease in a bunch of solid tumors, almost like a tumor marker. In a situation like this, you've got this pneumonitis, you can't really see any tumor. The pneumonitis is resolving. Any role for ctDNA in trying to decide whether to start therapy back up again?
So clearly in metastatic setting, ctDNA is useful to do target screening. So if you look for FGFR3 mutation or 2 amplification, but for monitoring the disease, I would be cautious. So of course, ctDNA may detect the molecular relapse earlier, but if scans are negative and the patient is off treatment because of toxicity, the key question is, what would I do with a positive result? If the answer is nothing until CT scan show radiographic progression, then ctDNA may add anxiety without changing management. So I would mainly use it in a clinical trial or if a positive result would trigger closer imaging or treatment reinitiations. But again, I would be very cautious for monitoring disease in metastatic setting. It's totally different from localized disease.
Subsequent to the recording of this program, the FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. This concludes our program. Note that the use of agents and treatments that are not approved may be discussed in this program, so check out the package inserts for more information. Special thanks to Professor Loriot and the case presenters, and thank you for tuning in. This is Dr. Neil Love for a Rapid Case Review.